Let's talk VDML with KJR.
Welcome everyone to another episode of Let's Talk VDML. I'm here with Kelvin Ross and Tracey Nguyen. So today we're going to be talking about a particular project that Tracey was really involved in. Both Kelvin and myself were also involved in. Is looking at de-identification of clinical notes. So these are the notes that either nurses or doctors might make in a hospital setting, and obviously really important for being able to use in a research setting or medical research setting, but also contain a lot of private information. So it's really important to treat them confidentially. So Kelvin, do you want to give us a little bit more background about that project or about the sort of the work that we've been doing in that area?
Yeah. This is part of the work that we do with Data-centric, which has been building the medical data platform with ICU data, with Queensland Health, and some work even with New South Wales Health and so on. And a lot of that is how we share the electronic medical records for researchers, for ultimately as a good basis for AI tools and things like that. But a lot of that data, it's real world data. There's something like 160,000 patients in the ICU medical database from Queensland Health, and that's made available to approved medical researchers to undertake studies and approved research projects. So they go through an ethics approval and a privacy approval for their project. But we still sort of de-identify all the data in that. So, what we're trying to do is to minimise the chance of information disclosure. The sort of ethics approval have looked at, we can share de-identified records as with approved researchers. So these aren't things being uploaded to the public cloud or anything like that. This is within a controlled environment, but still that practice of making sure that we've kept details private. And that's sort of part of, like in the US, there's HIPAA compliance is a well-recognised standard for sharing medical records. In Australia, we don't quite have that same standard. There's more an internal approval process in alignment with the relevant privacy acts that we have. And so we go through that process of de-identifying all the data, and then researchers get access to subsets of that data to conduct a research study. That de-identification process, it works pretty well. Like, for the structured data, we can pull out, the names and addresses out of the database pretty straightforward. But that gets a little bit more challenging when it's free text notes, right? Like, and sort of the HIPAA requirements are we need to remove all names, addresses, phone numbers, identifiers. So there's about 18 different criteria of what information needs to be extracted out of that data. So if we think about the medical record, it's a bit like a time series chart of the patient, and we've got all details there about their blood tests and all this sort of structured data. But as you said, Mark, the doctors and nurses were entering in free text information. And that information is really valuable for conducting a study. If we have access to that information, there might be something that wasn't coded in the medical record that we can actually analyse the notes and get a more detailed understanding of what happened to the patient, because it might not have been coded directly within the data. Typically all the medications are there, but things like we've got one study, for instance, looking at vasospasms, which is sort of like the blood vessels in the brain, and that isn't recorded as a structured field anywhere, so we go into the notes and pull that out. Similarly, we see that with another project we're doing at the moment around radiology imaging with echocardiograms and MRIs from cardiology, being able to pull out the diagnoses and stuff like that, because that hasn't been coded directly anywhere else in the records. So, those notes are very useful, but the flip side is quite a challenging problem to de-identify information in unstructured data compared to structured data.
Yeah, because you can't just drop, the first name column or the last name column or the address column. That information could be sprinkled in amongst all of that useful information. And it's very important to redact that private information, but you want to leave other aspects intact so that you can get the context. So we'd done a little bit of work already on, I think before you joined the project, Tracey, we'd done a little bit of work on evaluating out of the box de-identification models. And I think this is one of the things that we find really commonly and really part of the driving, I guess, reason for developing VDML as a methodology is increasingly we see the process is take an existing model and then see how well that works out of the box. Very rarely do we expect to try and build something completely from scratch that's going to do an AI task for us, as much as we want to take an existing model, see how well it performs, and then make some necessary adjustments. So I think we'd tried a few different large language models that were somewhat specialized, some that were even specialized for medical notes and had built-in understanding, if you like, of personal health information. And they performed pretty well on, if you like, the reference data sets that they might have been trained on, typically US data. And it was interesting to see that their performance was actually significantly worse on Australian data. Not just addresses, of course, suburbs and street names and things like that are going to be very different, but it was surprising to see that even the performance on like first names and last names wasn't as good as the reference data. So that caused us to sort of try and pick the best out of what we had and then do a little bit more of a careful evaluation. So Tracey, what was I think one of the first things that you had to do when you were joining the project was actually go through and do a bunch of hand labeling, right? So what was that like, just getting into this project for starters and sort of understanding how this was all going to work?
Yeah, in the beginning, it was a little bit confusing because I wasn't sure what I should be doing, and the interface, I wasn't used to the interface of the labeling tool. But after a while, I get the hang of it, and it's actually really good because, before the clinical notes got fed into the labeling tool, it's already been run by the model version 1 that you mentioned earlier. So lots of private information already been redacted out, and there's a label for them as well. So for example, we see a green label instead of a name. So we kind of have an idea of what information got redacted out, and we understand a bit of the context of the text. So yeah, that was what I did in the beginning. So we would go through redacted text and identify any private health information that fell through the cracks, and then label them manually. So highlight the text and select what category it belongs to. So if I remember correctly, we have name, age, profession, address or location, and maybe a few more. Yeah, but technically we highlight the text that got missed and put them in their categories. And yeah, that's what we did in the beginning. So technically identifying false negative. Yeah. And also we because as human, we read the whole text and we kind of can identify, for example, certain misclassification. For example, we see a redaction where it say name, but when I read the whole sentence, I can tell that it's actually a location, for example. And yeah, for example, I see Logan as a suburb in Queensland got mistaken as a name a lot, which is fair enough. But yeah, and again, I think we should also talk about the risk. Like that's a big thing that we talked about. So as long as the text got redacted, it got taken out of the context. So I think the risk is pretty low there, even though it's a misclassification. But in the grand scheme of things, it was a low-level error there. Yeah, so that's some of the observations that we had.
Yeah. So
that risk came up quite a bit, Mark. That you really couldn't just say, "Oh, I missed the suburb," or a date, for instance, could be a restricted item. So a lot of times it would come up, "Oh, it's missed the year." But a year on its own is not that high a risk of revealing because you're not pinpointing a particular date that a person was treated. So we found a bunch of errors that were being picked up that against the ground truth that wasn't being, say, detecting the full range, particularly when people write out in long form and stuff like that, and things get spread out a bit. But then when you look at the overall error in its context, then you would realize that's a low risk error. So that error analysis was still really important.
Yeah. So that, sort of two things, and I guess this comes back to lots of the challenges with evaluating the performance of language processing algorithms, even when you're trying to match up the semantics of a particular, two different bits of text. You can't just like look for exact matches or look for the presence of the same keyword. A lot of that context is actually really important, and not just the context of the sentence, but also the context of the task. So in this case, because we're trying to protect privacy, as you say, Tracey, it was more important to redact things that were private than it was to necessarily get the reason for the redaction exactly right. But there were a few other challenges, I think, like sometimes you'll have diseases that are named after people. So you'll see like a surname might get redacted when it's actually an important part of the medical information because you want to know whether someone has Hodgkin's lymphoma or something like that.
I think the big one was Brady, wasn't it, Tracey? Brady for bradycardia. They just wrote Brady in so often as a common thing that was being picked up as a surname.
Yeah, right. So that's, I guess that's another challenge, is that it's not like this is formally, like it's not formal English. People are writing a little bit in shorthand, right?
Mm-hmm.
And potentially spelling errors and all sorts of other noise.
Yeah.
You saw a bit of that.
Because, I think, again, it comes back to how did we evolve these models, and you sort of touched on it at the start, but, that whole process of iteration through transfer learning was really important. So we started out, like you said, with looking at off-the-shelf tools, so like AWS Medical Comprehend, and there were a bunch of rule-based tools that other data sets had used, but like you said, they are largely US-based. But we sort of used those to bootstrap that process, and then it was more an iteration of trying to refine the mistakes that those models were making to retrain the next iteration of those models. So you find just that distribution shift was the big challenge initially, and then later it was sort of fine-tuning these things that were more specific to language. And because a lot of the basis of some of these large language models might be things like PubMed and those properly written documents, but at the bedside of the hospital, it's a lot of shorthand and a lot of initials, like PT is used for patient and stuff like that, right? It's so it's almost, there's an element of learning that language that's being used within that context as well.
Yeah. So, and we were looking specifically at intensive care notes. So, it would be, as you say, normal to expect that the language that's used there is different from that in a medical journal. So there's that element of fine tuning for a specific task.
Yeah.
Yeah.
And interesting, we found that even certain kinds of notes were written a bit differently, and some had higher risk of having PII, private information, in it, or personally identifiable information, PII.
Yeah.
And so a good example of that is most of the sort of clinical notes, it might be the cardiology people, they rarely mention the person, they're just purely the doctor thinking about the disease. Where, you have a note about conversations with family or end of life care, there is a lot more discussion about the person and the relationship. So a much higher likelihood of PII data being in those kinds of records.
Yeah. And those, so the risk around some of those different types of notes are quite different.
Yeah. And we're sort of getting to the point then of targeting our testing a bit more to the higher risk areas, like pulling out statistically other areas where we think there is more likelihood of finding errors.
Yeah. And in those high risk areas, even with the process of hand labeling and getting that sort of like gold training set and gold test set together, we did a bit of, if you like, context limitation, so that the human labelers only saw a fragment. They didn't see like the whole transcription of that family meeting, for example, that might have had a lot of context about different family members. You just get like a couple of sentences, and then a different bit would go to someone else. So that was another way of sort of de-risking, if you like, the privacy process, or that redaction process, the testing process.
So maybe Tracey, you can comment a bit more about that, because you were sort of in that driving seat all the time in terms of, we deliberately split up the context to try to minimize disclosure of private information, but that trick of trying to give enough context so as a tester you could actually work out whether it was correct or not, right? That was tricky.
Yes, it was. Yeah, also because I didn't come from a medical background, so lots of Googling and to see, because not every private name is written with a capital letters. So yeah, we had to go around and look for information on that, and especially also geographical information. For example, I live in Melbourne. I don't know much about Queensland and what hospital you have out there, and all the hospital got written with abbreviation. So like certain hospital, and we have to go back to the notes from previous group to find out, what this information is. Is that a hospital or is that a service? For example, we got the flying doctor, emergency service, and those things. But to tie back to your question, the overall private information, a lot of it has been redacted out when it came into my hands. So I would think, yes, for the privacy side of things, it's quite secure. Not only that we only get fractions of the text, but also the text that we see doesn't contain that much private health information.
Yeah. I think one of the things that you really led, Tracey, once we got past that creation of the, sort of gold training sets and gold test sets, was really managing the process of refining how the algorithm was working. So classifying and working out what kinds of mistakes, what were the common mistakes that were being made, and coming up with ways of fixing that. Can you say a little bit more about that process?
Yep. I think when we did that, we prioritized things on the risk. So like I mentioned earlier, we got false negatives are the one that high up there in the risk factors. And within the false negatives, for example, name, a higher risk than, say, age or location, for example. So and then we also have another category of errors, which is false positive. And with those, like you said, Kelvin, where the medical condition got redacted out as a person's name. So with those one, again, like from the privacy point of view, they're quite low on the risk scale. So what we did with improving or identifying the areas, we focus more on the risk factors. So I think for us, a lot of data fell through the cracks because everyone got different style of writing dates. For example, June, some people write J and U, some JUN, and then July and or December DCM, for example. Yeah, so that was a bit tricky for us when we have to come up with the rejects filters-based model to kind of improve the performance. Yeah, and with our team, if I remember correctly, we mostly look at the dates for improvements in that front. Yeah.
So that was the sort of the strategy really, was taking that core model, that the actual machine learning component, identifying the sort of mistakes it was making, and then augmenting that with some additional filters that were essentially downstream from that model to then do further redaction.
Yeah, if I can explain a little bit that architecture, Mark. So again, like you said, we did a lot of initial model building and data set labeling with the sort of initial models, and that might get you to like 80 or 90% sort of accuracy. And that was good for that first pass. So when testers are seeing data, 90% of it's already redacted, and we're still dealing with testers that are signed to non-disclosure agreements and all those sort of privacy things. So you're still operating in a safe, like that typical data privacy 5 safes environment. But again, so most of that works pretty well, and that's created our first build. And then we really took a medical large language model based on BERT and another framework around it called FLAIR, and that created a name entity recognizer, so being able to tag out different parts of the text based on that sort of pre-processing. And that was the first build of the model, and we combined a bit of the tools like filter and DID were based on regex rules and things like that. So as we sort of ran it and identified the errors, like Tracey said, we'd see classes of errors, and then we could add post-processing to that, to add regexes to sort of catch some of the confusions that were coming up both on the false negatives and false positives, to build an improved sort of gold standard or test set and data set that then we could also run more broadly over all the data to create a lot more training data. And then we could iterate and build another version of that large language model tool to then pick up some of those nuances that it hadn't sort of picked up in previous iterations. And then we could sort of step through those. So there was quite a few iterations of refining those sort of regex rules to sort of improve the broader labeling across the broader data set.
Yeah, I guess to sort of summarize that in sort of the things that we're often looking for with validation driven machine learning is by taking that base model, evaluating it, like seeing what kind of mistakes are being made, and then doing essentially simple things to improve the performance, to catch those edge cases. So although, Tracey, I'm sure you and the team, no one likes writing regular expressions. I don't like writing regular expressions. So it's a pain, right, to get them really working reliably and not catching too much or too little. But relatively simple, low cost improvements. But those two things in combination allowed us to auto label, like create a whole bunch of new training data and test data that was sort of fine-tuned, that we were quite confident was worth then pushing back through that machine learning process so that we got an overall improved model. So it's not like you have to start completely from scratch, hand labeling everything. As you say, if we'd done that, you would have seen everything already raw and have had to label everything instead of just picking up the deltas.
Because I think the power of that is, being a very data-centric approach. Our data set's got millions. I'm not sure how many nodes it had, but you're talking about millions of nodes, and using these tools, and through your error analysis, you detect a pattern of something that's being not picked up properly. It's not too hard to write a regex to go and find that in all your data, right, and pull out all the other examples that might be exposed to that kind of error, and then sort of pick those out, correct it, say how it should be labeled. And that way you're sort of creating training data that's very focused for the model about correcting that sort of behavior. So that data-centric approach is really quite powerful. What you don't know is what's going to keep coming up as new notes. You're still going to get distribution shift as you're in production, but that's where you're trying to build a robust generalizable model, that because we had such a large intake of 8 years of data, we actually had a huge database to actually refine and check and build a very robust sort of model that's less prone to distribution shift.
Yeah. So that's sort of a point there where, if we were running this, continually in production, you'd want to still do some spot checks and have, the human in the loop at that point to go, is this thing still working?
Yep. And that's certainly, the case that any researchers that do come across PII that has been disclosed, they're under contractual obligation to notify, obviously under the 5 safes model and their contract and their non-disclosure agreement. It's not public data, so it's not like that's out in the real world. But if things do slip through, having that process of those humans going, oh, hang on, there's something not being picked up here. How has that slipped through our sort of process, and how do we iterate and improve on that?
Yeah. So what were some of the key takeaways for you, Tracey, from, jumping in? As you say, it was a bit confusing at first. It's not like you were coming specifically from a medical background. By applying, these different stages, what was, what did you sort of take away as your sort of like key learnings?
Yeah, I think for me, the key learnings are, first of all, the model needs constant improvements, and also all the data are very specific to the context that you're testing. For example, if we build a model for Australia and we bring it to China, I think we can see the drop in performance. So the aim is to build a model that works in the context that we train it to, but when we bring it to another location or another profession settings, will have to be retrained. And sounds like it's a process. We can't ever get into the end with 100%. Simply that's impossible. And second of all, for me, is the separation of, like you said, test set and validation set. We need to have a separate, complete separation between the two to ensure the integrity of the model and make sure that what we train are actually be improved, rather than the model learning from what it's already seen. Yeah, very important learning for me, with someone who get into machine learning for the first time.
Yeah. Well, and I think I certainly anticipate that there'll be more of this. I think after that initial project, you went on to do a lot of similar coordination for a computer vision partner of ours, Smart AI Connect, and we'll probably talk about them in a future episode, and that'll be another whole, set of challenges that are different to this sort of text-based stuff. Do you think that there's going to be more and more model testing in your future?
I would love to do so. Yeah, and like you said, AI and machine learning is the future of technology. So I can see there'll be lots of work in that space. And yeah, it'll be interesting to get more into it, of course. Yeah.
Awesome.
Yeah, I think I think those are really good points that Tracey made about the takeaways. And I think that's what we find is that, your context, the out-of-the-box model rarely works the way you expect it to, right? Because of that change in data. So it's really important to think about the narrow area of task application that you expect them to work in and really focus on measuring the performance of that. But I think what we're seeing from this process, which sort of existed a bit before the chat style models and the open AI models that really exploded like a year and a half ago, it was still large language models, but used for a very structured functional example. But I think we're going to see exactly this process. Well, this is what we're finding now is exactly this process is rolling out with those generative language model tools as well. That again, we're probably not as closely testing the functional behavior as we have done with DID because there's a very clear functional accuracy thing it has to perform. It's probably a bit different to a summarization task or a translation, but the process is almost identical. How do we benchmark where it's at? How do we iterate and improve? Probably the difference there is that what I'm quite excited about with the new generative tools is how quickly you can write those prompts for the sort of zero shot and few shot learning examples. So very accurately they get a bit closer, but then you find they're not performing quite that well in the corner cases. So even like in this DID tool, how we, instead of writing regexes, do we write prompts in large language models to look for patterns as opposed to sitting down and writing basically, as you said, it's not much fun writing regexes, right? You sort of the pattern languages, but I can see how more generalized different patterns are, say in a few shot example where, you just give that to the large language model and say, hey, here's the kinds of dates I want you to look for as another check on the data at the end.
Yeah. And I can certainly see that we'll keep bootstrapping more and more of those specialized, tools and techniques for ramping up the optimization process in much the same way as we did here, and that Tracey, that you led with really making that auto labeling process more efficient so that we're not spending a lot of human hours just marking things up as much as we're checking the work of the machine and going, yes, that's better, that's an improvement, you're making a mistake here. So onwards and upwards. I think we'll see probably a whole different class of challenges emerge over time as we dive deeper into all of this. But I think that's time flies when you're chatting about machine learning. So we probably should wrap this session up. But thanks to you both for spending some time, and we'll look forward to seeing you. Well, we may very well see both of you again in a future episode.
Yep. Thanks, Mark. Thanks, Tracey.
See you, Kelvin. See you, Mark.
Bye.